Good morning. We will shift gear and look at anticoagulation, looking at what we refer to as DOACs or NOACs, the direct anticoagulant agents or new anticoagulant agents. We will look at two things in this presentation. The first one will be just general issues about VTE, that is venous thromboembolism, covering both DVT and PE. That's going to be the first section, just looking at the general issues. And then the second part will be to consider what we have on the market, focusing mainly on the bigger trend. First of all, the epidemiology of VTE we understand. Just to mention clearly that it is the most common cardiovascular disease worldwide after ischemic heart disease and stroke. And in this country, just talking to colleagues and observing what's going on in the clinical scenario, there is a worrying trend of increasing DVT and PE. And it would be good for physicians to reflect on what the key issues are. In the US and in Europe, the mortality rates are significantly high. And we can say the same thing over here from anecdotal data, hoping that at least we have enough threshold of physicians to be able to look at what our local data is. These are the risk factors, as we all know them. I think on the left side we have trauma, surgery, all the way down. This looks like the typical patients we have in our medical and surgical wards. They all present as risks of VTE. And then we do have predisposing factors and patient characteristics. Again, people who have suffered any event in the past are likely to have an event, a VTE event, and all the way going to advanced age, immobility, we have hematologic conditions, pregnancy or peripartum periods, and estrogen therapies. Again, looking at estrogen therapies, I think I was talking to colleagues of mine last night, the worrying trend of DVT we see in young women. And that may be linked to the types of oral contraceptives that they use. I understand we now even have herbal oral contraceptive pills. I'm not sure how much estrogen or progesterone there is in that. Now, looking at the risk, the VTE risk in surgical patients, I think it's very clear if you look at the list right on the board. We have low risk, moderate risk, and high risk. Most of our patients who undergo total hip replacement or total knee replacement, usually that predisposes them to a moderate risk. Obviously, you know they require prophylaxis immediately after surgery. That tends to go on for either a few days, depending on the regimen you choose, or about a month or so. And then we do have patients, high-risk patients, especially those with spinal cord injuries or after major trauma. Major orthopedic surgery, again, is an important risk factor. I think we do have the statistics over there, looking at our own medical patients in our wards. I know some of you in your own hospitals, you've begun protocols for detecting patients who are at high risk for DVT or PE. And I suggest that, or propose that we should make it a policy nationwide, that we should be able to have protocols across the country to be able to detect our medical patients who are at risk of DVT. And going down the list, obviously, we do have a higher risk, for instance, in patients who have had surgery or stroke and other trauma events. So, in terms of managing patients with VTE, usually there are three phases. There's the initial phase that we all do as physicians to get the patients out of the initial phase of risk, and then we do secondary prophylaxis, and then eventually there is the extended prophylaxis, depending on the predisposing condition, whether it's been managed acutely or is something that will persist for a long period of time. And what we'll be looking at in the coming few slides is to look at what agents do we use in the first phase, second phase, and the third extended phase. Now, these are the goals. for treating a clot. First of all, we can be able to prevent further clot extension. We can dissolve the clot, the agents that we do use to do that. And also we can be able to prevent post-thrombotic syndrome, varicose veins, and also the attendant pulmonary hypertension, which tends to come after patients have suffered from VTE or PE for that matter. And therefore, prevention of recurrence is another major issue we look at. And this slide summarizes some of the things that we normally look at in terms of the initial management, second prophylaxis, and so on. So for initial management, that tends to take about 5 to 7 days. We're all familiar with that. The patients tend to have some sort of parenteral therapy, and then you can go to second prophylaxis, and that is followed up on that. So we may choose to use either unfractionated heparin or low molecular weight heparins. One may choose to use thrombolysis depending on suitability of patient selection, or vitamin K antagonists. In our environment, we use warfarin throughout all the three phases. Now, there are limitations in using the vitamin K antagonists, especially warfarin. We know it is widely available, it's accessible, it's affordable to most of our patients across the country, but there are a number of limitations, however. And again, I don't want to belabor this, just looking at some of the issues over here: slow onset of action, narrow therapeutic range, especially if you are looking at VTE. There is the issue of warfarin resistance, and then numerous drug interactions and drug-food interactions and so on. And also you require to monitor that very closely. And therefore, in conclusion, we know that the use of warfarin or VKA therapy has several limitations. The other thing I probably may want to caution colleagues is that the fact that you have a standard target INR usually doesn't guarantee you that you've achieved the proper anticoagulation. That may not necessarily be the case. And therefore, there has been need in the last couple of decades to be able to expand the treatment of VTE, looking at other alternative therapies, especially the NOACs, which are usually administered orally. You can be able to use them in acute treatment or also prevention of recurrence. And we do have a number of agents. I think there are 4 now approved. There are 4 currently approved. We have rivaroxaban, which sells in this country as the Relso. We do have the Bigatron, Etaxidet, which is sold as Pradaxa, and also we have Pixaban, which sells in this country as Eliquis. I'm not sure whether we have Endoxiban, but they are available in the country, both for acute treatment of DVT, PE, and also reduction of risk going forward. And we will then look at how these new treatments are used for VTE. Now, we've already gone through this, so just perhaps looking at how we then, how those particular agents act, off the slides, how these particular agents act in the coagulation cascade. Now, the vitamin K antagonists, we know what they do. They do antagonize vitamin K. I'm off the slides. The normal agents, or the NOAC agents, have specific, they're specific molecules, and they do act on different parts of the coagulation cascade. We do have the vitamin K antagonists, as I did say. They tend to antagonize vitamin K, which is important in the cascade for coagulation. Then we have a direct factor 10 antagonists or inhibitors, and those are the 3 main ones: apixaban, rivaroxaban, and edoxaban. As I did say, we do have these agents available in the country, at least these 2, apixaban and rivaroxaban. And then we have direct thrombin inhibitor, and the agent we have in this country is dabigatran. And these are the properties of the new agents, so the NOACs. If we just look at a few of these without having to belabor all of them, if you look at dabigatran, for instance, half-life is about 12 to 14 hours. Rivaroxaban 5 to 13, and then apixaban about 12. Protein binding tends to be much higher for rivaroxaban and apixaban compared to dabigatran. And then in terms of dialysis, is it possible to remove the agent via dialysis? Yes, for dabigatran. And this is important in terms of determining whether you may want to remove the agent in cases where patients bleed, or whichever reason may have to remove the agent from circulation. Then we have renal clearance for dabigatran, 85%, and then this goes lower for the other agents. Again, an important aspect whether you need to adjust dose depending on creatinine clearance, involvement of the cytochrome P family enzymes in the liver, again for dabigatran none. And for all the other ones, there is significant interaction. Again, this is important if you're going to give other drugs that influence the CYP, like the fluconazoles and so on, and that's important. So let's look at the acute treatment prevention of DVT and PE. We'll focus on dabigatran. This session was kindly sponsored by Boringa. So look at this and compare with the other agents in terms of just reflecting on what evidence there is out there. Now, I hope the slide is clear on the other side. So these are the many clinical trials that have been performed in the last few years, looking at the efficacy of dabigatran compared to the standard treatment, which has been warfarin. So we have the RECOVER trials and all the other trials, all across for the other agents, NSTEN, for rivaroxaban and amplified for apixaban. Too many complicated names, but the message here will be clear in terms of what was the comparison. For acute treatment, obviously, dabigatran, the dose was 150 milligrams twice a day, and the comparator in this case was warfarin. I think that's just the message out of this slide. Treatment duration is about 6 months. In statistical tests at this particular level here, this is non-inferiority, meaning that the two of them were comparable. And then we look at, again, the second part of acute treatment and prevention of recurrence. Again, just focusing on dabigatran. Again, we can see in the first case, this is a limited trial, the comparator was warfarin, and then in this case, for so that this was compared to placebo. Again, duration of treatment, 6 to 36 months on the one side, and the other one 6 months, and 12 months additional follow-up. I have put these names over here because we often meet these names and they tend to be very confusing. What I'll do in the subsequent slides is to tease out the evidence that supports how to use or when to use dabigatran in acute treatment, and also how or when to use it for long-term follow-up. So just looking at the conclusions for dabigatran in terms of acute treatment, this has been shown well from the clinical trial and also mirrored in actual practice. There's been long-term evidence, just looking at the data from prescriptions, especially data from insurance companies and general practice in North America, looking at whether the evidence out there reflects what happened in the clinical trials. Now, this is one of the most exciting slides in terms of just a reflection that whatever happens in clinical trials, where we have patients highly selected, tightly controlled on the left side, and then in real world, what happens is we have a broader patient population, And one can be able to look at how these patients perform on treatment and the risks that follow after that, especially in terms of these 3 points here, confirming the results from the clinical trials with the drug is actually efficacious, and also looking at the safety and effectiveness of the drug in terms of looking at some of the complications. For instance, the analysis that consistently showed that both the dabigatran doses had a favorable safety profile compared to warfarin. This is a large number of patients looked at in real life, and just looking at these figures over here, that for major bleeding, which is defined as significant bleeding that will lead a patient to require hospitalization, this was reduced significantly in patients on dabigatran compared to VKA or warfarin. Now, when we look at dabigatran versus warfarin, the treatment of DVT, again, these are the two major trials, and I just look at what the conclusion was. One was there was no dose adjustment in this patient population. Of course, we do know that if patients have a creatinine clearance less than 50, or between 30 and 50, maybe need to reduce the doses, and if the patient's creatinine clearance is less than 30, obviously the dose will need to be reduced. Need for parenteral lead-in. Most of you are aware that patients tend to have parenteral therapy prior to initiation of oral treatment. And again, this was compared to standard care. And the primary endpoint for this was composite recurrent symptomatic VTE and death related to VTE in 6 months. And then the safety endpoints are the ones that I didn't mention: bleeding or any sort of bleeding and other adverse events. I'll skip this, it's quite a busy slide. But in an acute treatment, dabigatran, non-inferior to warfarin, prevention of, for prevention and recurrent DVT, again, that was quite clearly demonstrated in this particular study. Now, one of the other things that may be useful to look at, and I think most of you who give patients NOACs know this, a lot of our patients tend to complain of dyspepsia and so on. Again, that is true, the incidence of dyspepsia compared to warfarin, but the overall lower rates were seen in the real-life trial. That real-life trial was looking at atrial fibrillation. We aren't looking at that at this particular time. Most of you who look after these patients are aware they tend to complain of dyspepsia, which we have standard treatment for. Now, the benefits for dabigatran versus warfarin in acute phase of treatment are clearly indicated: reduction, major bleeding 40%, major and clinically relevant non-bleeding 44%, and any type of bleeding reduction 33%. This is compared to warfarin. And in this particular study, looking at warfarin in extended treatment for DVT and PE, that is long-term prevention. And again, the conclusion is down there in red, that dabigatran, the only NOAC to have been compared to warfarin for a longer period of time. Perhaps it's because it's been here longer than all the other ones, and showed efficacy and safety in terms of long-term prevention. I won't go through the characteristics of this particular study, but however, just looking at, again, the conclusion for prevention of recurrence for patients who receive this treatment long-term, the risk at 18 months, again, was lower in this particular patient population compared to warfarin. And again, just to emphasize, looking at the bottom of that slide, the 46% reduction in major or clinically relevant bleeding with dabigatran. Now, this slide shows us information almost similar to what has been demonstrated in the previous slide. We're just looking at, again, the bleeding, and so on. The safety of this drug, especially in terms of bleeding. Now, what I may want to do is look at the primary endpoint in long-term prevention, and that is 92% reduction in risk of recurrence of VTE, which is quite a large percentage if you look at giving patients to prevent recurrence of VTE. And interestingly, even after discontinuation of the Ligatron, if you look at that particular point, the benefit was still visible many months, or demonstrated many months after discontinuation. So, bleeding events again, just to come back to that, the incidence of bleeding was low in both groups. The major clinical relevant bleeding was much higher in the bigger compared to placebo. And again, just to belabor the point that the safety aspects of this new agent was much better. Probably need to go through towards the end of this slide. We often grapple with as physicians is, what do we do when a patient presents with a complication of bleeding? First of all, in general, these patients will have to be treated like any other patient who presents with bleeding. They need to be assessed. We need to put in place all the emergency measures for bleeding. That's the standard care, whether it's mild bleeding, moderate, or major bleeding. Now, we also know that it may be necessary at the beginning, looking at different agents, either whether you're going to begin using parenteral therapy before you initiate oral therapy, or you may want to start with oral therapy right from the beginning. In general, it's acceptable that patients will require to have initial parenteral treatment before then they go to oral treatment. But then the other thing that we might want to look at is when patients do present to us with bleeding, what precisely should be done? We are aware that for dabigatran, there is a reversal agent, and so there is a reversal agent approved in 2015. In this country it's not available, but we hope to be available soon, that can be given to reverse any event of major bleeding. But let me just finish up by saying, why should we choose dabigatran over the other agents? First of all, it's the first for stroke prevention in atrial fibrillation, and now it's used in DVT-PE. The only NOAC available with data for extended prophylaxis, and again, because it's been here for a much longer period of time, and the only NOAC that has a reversible agent in the region, as I did say a short while ago. Simple dosing, default dosing is 150 milligrams twice a day. We do have other dose formulations available, 110, and I have seen some patients coming to us with 75. Perhaps we'll be able to answer questions to that later. And dose adjustment may not be required, but there are specific areas where we may need to do dose adjustment in renal patients. And then, of course, parenteral sub-Q leading option for inpatients in the country. I think these are the last few points to mention. Number one is the phase 3 trials for VT treatment, showing clearly that dabigatran has similar efficacious properties and also reduces major bleeding compared to warfarin. In extended prevention, obviously it's much better than the VKA or warfarin, and also it is convenient to be able to give patients, because we no longer need to do regular blood tests like we do for warfarin. Thank you very much.
I'm Dr. Dilip from MediHill, and I have one question for Dr. Bukachi. He suggested extended prophylaxis in deep vein thrombosis after the duration of 3 to 6 months. The duration and what are the guidelines we follow, and those who are with protein C and S deficiency, lifelong prophylaxis, what should be the dose of the NOACs we use for them. Because I have patients, I am using still NOACs still now more than a year.
A large number of people who have atrial fibrillation, at least in our environment, is driven by valvular heart disease, and we had some difficulty with Pradaxa earlier on, and it has made several drug companies shy away from recommending using NOACs for atrial fibrillation when it's in the setting of valvular heart disease. We have some interesting data that will be coming out soon with the use of Xarelto and trying to see whether it works with rheumatic heart disease. But Dr. Bukachi, what are your thoughts as far as perhaps experiential encounters with people who have valvular heart disease that's structural with use of novel anticoagulants?
Valvular heart disease and the NOACs, none of the companies recommend use of that, because the clinical trials looked at non-structural valvular atrial fibrillation. So that's the indication. However, we know off-label there are a number of physicians and cardiologists who do that. I personally don't. I still put my patients on warfarin. We are still waiting for the interesting data you're talking about. I'm aware of that with the rivaroxaban. So we hope that that will be able to guide us on whether that is a clear indication. The other question is to do with how long extended prophylaxis should take in patients who are put on what we call extended medication. How long, the clinical trials are not clear about that. That's why they say it may be months or years if the risk is still available. For instance, the patients you talked about who have hematologic conditions like deficiency of protein S and C, those kind of patients will require long-term anticoagulation. The question you asked was, what dose? Again, I think the dose will probably be slightly lower than the full dose. If you're using the bigger tram, you probably may want to come down to 110, and if you're using the rivaroxaban, you may want to come to a lower dose, either 10 or so, and the pizzaban, you can come down to much lower dose. That would be a pragmatic approach to that. The last half question, that was a comment from Dr. Yosa, very important. I didn't put that on my slide. HIV/AIDS, any unexplained intravascular thrombosis, we must screen our patients for HIV. And more importantly, for elderly patients or patients above the age of 50, we should aggressively look for a possible tumor. We have seen patients with multiple myeloma, recurrent thrombosis, unexplained, and the disease comes up late, about 3-4 years after the initial diagnosis. Thank you very much.
Thank you.